David, thank you again for doing this.
No problem.
So we're going to be doing a presentation on hospital-acquired C. diff infection today. So, focusing on these core areas for our presentation, gastrointestinal system, specifically the microbiome that's involved, and normal parts of that biome. So, microbiome is a complex combination of bacteria that live together in the body system. There's different bacteria present. Microorganisms that coexist in the microbiome depend on the environment. Some of them live in, so there's plenty of different bacteria that are present on microbiomes throughout your whole body. Some bacteria like an oxygen-rich environment, some bacteria more of an acidic environment, and environments a combination of both bacteria. So for this presentation, like I said, I'll be focusing on your gastrointestinal microbiome. And there are a lot of different organisms that survive in that area. Compiled data from a study I looked into identified over 2,000 species isolated from human beings, classified into 12 different phyla. 93% belong to the Proteobacteria. Let's see, the remaining percentage was Actinobacteriids and Bacteria ducts. No two people have the same microbiome either, which is interesting. You can have very similar bacterias, and partners that live together in the same environment, they tend to have very close biomes, but again, not identical. It's interesting. So factors that can influence the bacteria in your diet include, or in your microbiome, include diet, exercise, medications, and maybe even genetics. Types of bacteria that make up in your home environment tend to kind of thrive in your microbiome. That's interesting.
Makes sense.
And so the main pathogenic bacteria I'm focusing on is Clostridium difficile, which is C. diff, as we know it.
We're familiar.
Very familiar. And it doesn't provide any benefit to the body. It affects its environment in a very negative way. And the microbiome that's good for your gut, which is the normal bacteria found there, outcompete this pathogen most of the time. And that's when the bacteria the pathogen takes over, is when those bacteria levels fluctuate or drop. Let's see here. So, prophylactic antibiotics, something we deal with every day, especially on the Magnolia Tower. Right after surgery, we start you on the IV antibiotics. Usually it's cefazolin, sometimes it's Recefin. Surgeon preference. Question that I was wondering if it was, how necessary is it? If they're not spiking a fever, they're not, we do pre-op labs, everything looks normal, they're healthy individuals. Is it absolutely necessary to start them on that versus the risk of developing a hospital-acquired infection? So those antibiotics can be very tough on the gastrointestinal system. Let's see, there's a lot of research and evidence on the best practice for postoperative infection prevention. The most prevalent cause of C. diff infection is, this is a Canadian study I looked into. It's highly correlated with antibiotic use in contact with healthcare facilities. So even just being in the hospital, of course, is a risk. That bacteria, especially, lasts for a long time. Even though we do here at Inlet treat it very effectively with the UV light. But yeah, that article, it's based out of Canada, found that preventing infection and loss. So they looked at probiotics in combination with antibiotic use. So
Okay.
probiotics are the good bacteria. They're a combination of the three that I mentioned earlier, the proteobacteria and the other two.
Okay.
And so the idea is you take these to help prevent the pathogenic bacteria. Even if it does get in your gastrointestinal system, you're trying to bulk up those good bacteria to prevent the bad from taking over.
Right.
And so the combination of probiotics and antibiotics to increase your lactobacillus, specifically that one, fortified your intestinal system, and prevented pathologic bacteria strains from invading. And then also it had a direct effect on C. diff infections, respiratory tract infections, and there was a lot of evidence to back that up, that it benefited you to take the probiotics before, during, and then after surgery.
Okay.
Another thing I looked into was fecal transplants. It's been around for a while now, but it's very low risk of side effects, kind of a newer treatment, and you're taking fecal matter from healthy donors and taking that either oral or they can instill it. But that, yeah, it's
Not the most appealing treatment.
definitely not, but it's got a lot of stigma for it, for sure. But definitely promising, and patients have been turning towards fecal transplant for alternative to non-pharmaceutical. Promising. This is very promising therapy. You don't have to be on antibiotics. Actually, got to watch a presentation done by one of our gastroenterologists, Peter Bankson, and he was talking about 85% success rate after the first dose in getting rid of diarrhea.
Wow.
Altogether for
That's
CDIFF
great.
specifically. Also mentioned that it could help with chronic conditions like gastroenteritis, maybe Crohn's disease even. The main thing is it's still kind of a newer treatment, so a lot of research is still need to be done on the effects of this treatment on chronic conditions like gastroenteritis. Okay, so compared with antibiotics, fecal transplants improve patient survival by more than 30% lower risk of deadly bloodstream infection, sepsis. It can happen from antibiotic treatments. Sometimes that can happen, and cut length of hospital stays in half. That was from a study done in 2019. So yeah, in summary, your microbiome balance is very important for not just your postoperative patients or hospital patients. It's for everybody. Antibiotic use or overuse is something that needs to be more research done. Definitely surgeon preference, but taking probiotics has been shown to help prevent C. diff infections, treat them. And more research needs to be done on that as well. Actually, that's what I looked into. But yeah, the probiotics are more effective when started sooner rather than later. Fecal transplants are not the mainstay of treatment, but hopefully become more and more available over the next decade, as efficacy can be denied from the two studies I looked at for C. diff, ulcerative colitis, and Crohn's disease. Here's the copy of the diarrhea decision tree, which they provided me with. It's a great resource. I've used it here a couple times. So, sometimes we give a lot of medications here that can give us false alarm or
Yeah, that's a good tool.
oh, this is related from magnesium citrate the patient got, or maybe some kind of infection.
Right.
And references. Any questions?
I really thought, I found it really interesting. We almost got to the 10 minutes. Anyway, that we all have such a different flora based on our environment, but it totally makes sense. I thought it was cool that the data on the fecal transplant showed such a good result, but that it's not a mainstay treatment yet.
Yeah.
When it looks like it can be given like just via capsule form.
Yeah.
Even. So that's kind of interesting to me that there's evidence on that much success, but we're not using it on any level. The evidence you gave on the prevalence of C. diff and how it occurs directly correlates to what we're seeing on the floor. So that seems very accurate. What else did I have? I know you discussed the ANSA Frocephin as possible causes, like too much antibiotic therapy is a possible cause. I didn't hear you talk about, which might not be as relevant based on your focus, but how we use like oral Vanco to help treat it.
Okay.
You know, like in combination, like it sounds like maybe a great combination would be the probiotic, a fecal supplement, and an oral Vanco dose could really turn people around really quick.
Yeah.
That was my only thoughts based on what we know as nurses.
Okay.
But other than that, I don't have really any major questions because you covered everything.
Oh, thank you. Well, that's an interesting thought. For this study, for this presentation, I was focused on fecal transplant and probiotic.
Right.
But maybe a spread of them would be.
Yeah, something that might be kind of interesting to people that we know about is like once people have had a C. diff infection, like how long does it take for the local infection control to clear people? Once they've had it, because like if we get a patient that leaves and they've had C. diff within a few weeks, but they come back, we still isolate them as a precaution.
Even if they don't have diarrhea.
Until, Dr. Courtney in infection prevention clear them.
Yeah.
So that's kind of an interesting twist on it. Kind of sticks with the patient for some period of time until they get cleared. So I think that part's interesting. But yeah, good job, man.
Yeah, thank you, David. I look forward to hopefully there's more research done on this because maybe modality of treatment of the Vanco, and the fecal transplant especially. There's still so much stigma, or just maybe.
Well, it's not appealing.
It's not appealing.
You're going to have someone, hey, we could do this, and they'll be like,
I don't know. Sometimes those patients stay here for like 3 or 4 days getting their oral Vanco.
And if it's a tasteless capsule, that would change the appeal of it. It's like, okay, this is an isolated microbacterium. This is not, I'm not eating.
Yeah, then scoop this out of a cup and
right. So there's probably a stigma with that.
But hey, I'd take that over 3 days extra in the hospital.
Well, and how miserable it is in dehydration. No, that was really good. I liked it.
Awesome. Thank you, David.
Yeah, no problem.
Yeah,
very good.
Stop
I think I have you at like 12 minutes-ish.